optimal surgical management of this patient. Primary peritoneal drainage, laparotomy.
Our village boys.
There's a lot of debate about which is better for these children. Initially, when primary peritoneal drainage came in, it's like, oh, it's a stopgap before you go in for laparotomy. But many studies have come up to show that some of them end up needing only this intervention, and they go on to get better. Traditionally, peritoneal drainage is done when patients are unstable, so that when they become better, laparotomy can be done. At laparotomy, you have more chance to examine what is happening, what is the condition of the bowel, and then to give appropriate treatment. Standard treatment right now is resection of the necrotic bowel and stoma formation. But there is room for primary anastomosis, which is a bit controversial, but has its own advantages in that patient will not need to come back for and you avoid stomach complications, which occurs in more than 50% of those that go on to have stomas. At laparotomy, the intestines are examined. There are different scenarios that you find in necrotizing enterocolitis. You can have a focal disease whereby some segment of the intestine, just a single segment of the intestine is involved. In this condition, sometimes they may be amenable to primary anastomosis, but most of the time, because of the pathophysiology of the disease, which there is bile ischemia, so sometimes even if you do primary anastomosis, they go on to leak, and you now need to go back to do another surgery, which increases the morbidity and the mortality. If it's you can find a multi-segment disease but there's less than 50% of the intestinal length involved. In these situations, there are different ways you can approach it. If there are areas of questionable viability, you can go into damage control. You can do damage control surgery, whereby you close the abdomen up, hoping to come back in 24 hours or 24 to 48 hours to see whether there is some recovery. There is you can do there are some technique like the patch and wait, clip and drop. Patch and wait means the bowels are so patch and wait, clip and drop. Patch and wait means the bowels are so patch and possible you clip and drop. Patch and wait means the bowels are so do what they need to you can clip and drop. Patch and wait means the bowels are so do what they need to you can clip and drop. Patch and wait means the bowels are so do what they need to you can clip and drop. Patch and wait means the bowels are just where less than 25% of the small intestine is
you drop all the items.
In this condition, or if there is total intestinal gangrene, there is the room to forgo treatment. In that situation, the surgeon may organize an MDT right there with the anesthetist and with the neonatologist and the parents, and a decision may be taken to forgo treatment or not to do anything. Or all the intestine can be resected, and the patient planned for intestinal transplantation, which is not feasible. Most of the time, is not feasible at this point in time. Can we have the next slide, please?
Different kind of things. Share. Oh yeah.
The next slide.
By Bluetooth. Is it share? What do you do? Send by Bluetooth.
Well, the next slide is still talking about. The next slide, I'm talking about spontaneous intestinal perforation, which is one of the conditions that come into discussion when talking about necrotizing enterocolitis. This is a situation whereby there's a single perforation most of the time in the distal ileum. Most of the other things that are involved in necrotizing enterocolitis is not present. There is no radiological features of
Things that
necrotizing
you're reading off.
enterocolitis.
Okay.
This happens in
The
many
iPhone
of the
too.
patients
That's
that
the name
have
of it.
been on NSAIDs to treat
Connection to
the patent ductus arteriosus.
àwọn phone
In
tí
these patients, there's a lot of debate
phone
which
ní
also go on,
phone ní
like what is happening in necrotizing enterocolitis. Will you do primary anastomosis or you come out with stomas?
phone
Some of the patients that have gone on to have primary anastomosis
where I go
unfortunately end up with
why
leakage. It's also related to the pathophysiology of this condition because of bowel ischemia. So if primary anastomosis is done, the risk of leakage and the risk to still go back for a redo surgery is there in these precarious patients that are unstable. The long-term management of this of
kíní
necrotizing enterocolitis surgically
àwọn
include,
kíní
like, if you have created a stoma, you have to go and close the stoma subsequently. But more importantly, even the patients that end up not going in for surgery, those that have been managed medically, they end up developing strictures which end up presenting as
is your battery
intestinal
still okay
obstruction subsequently
Mm.
in the near future. So these are some long-term problems that they have. They can also go on to
Yesterday,
have
somebody.
a endoenteric fistula.
my
Then,
so you have it no
Oh, yesterday.
you get what I'm saying
Okay.
because of the bowel resection that is very commonly done in these patients,
Okay.
they end up with short bowel
Okay.
syndrome, which they may need to have
promise
autologous intestinal surgery later,
Okay.
bowel lengthening procedures
Okay.
later.
you have to leave it open this way
Okay.
Next slide, please. Next slide. So prevention strategies are like the first speaker has stated, is um, what is our that is what is the main, because most of the effort and strategies that have been put into this condition has not changed the mortality rate significantly in the past 30 years. So it's a frustrating disease actually that has plagued the NICU, and unfortunately it's affecting more than a third of of babies admitted into NICU. The operative strategy chosen by surgeons has not, from studies, none have been validated to be superior to any. So that is why the the controversy about what to do for these patients. So in conclusion, the strategies that identify features of impending neck. Identifying the features of impending neck is very important in this patient, so that before before the before the problem starts, the patients can be the patients can be so sorry. So the strategies to identify the factors indicative of impending neck need to be um, uh, streamlined with close collaboration between neonatologists and surgeons, so that a patient is admitted with neck. Sometimes he needs serial monitoring. Some centers have done eight hourly radiographs, even though this has all been controversial, eight hourly radiographs to continue to find out, to know exactly when should surgeons intervene in some of these patients. Most of these strategies have been questioned because many studies have also shown that even without surgery, some of these patients go on to do better. So these are all the issues that make the management of these patients quite challenging. I've tried to bring out some of our experience here in National Hospital. I discovered that most of the time our patients here don't even get to the theater because we have a lot of problems with coagulopathy particularly. They have thrombocytopenia and the anesthetists never agree to allow this patient and allow us to get to theater with this patient because we need to resuscitate, and in the process we end up losing the patient. So I couldn't find much data, though I know we have done some surgeries on some of these patients in National Hospital. Thank you very much.
Thank you very much. Thank you very much, Dr. Roche. Which one am I saying?
What I thought was
Should I activate this?
Thank you very much, Dr. Roche. And thank you also, Dr. Maria Mutariola, for that excellent exposition on necrotizing enterocolitis. Even I am not a neonatologist, but I've learned a lot of new things. Now, can we take questions and answers? Please indicate who you are asking or directing the question to so that the appropriate person can respond to you. Can you indicate by lifting a hand, please? If you wish to ask a question, can you please indicate by lifting a hand?
I see some hands up. Ms. Saleh Hassan.
Okay. Okay. Starle Hassan, please go ahead with your question and indicate who you are asking,
Good afternoon,
directing.
ma'am.
Good afternoon.
Good afternoon. Good afternoon. Thank you very much for the wonderful presentation. It's highly educative. Please, ma'am, I want to know, clinically, what, how can you differentiate between necrotizing enterocolitis and spontaneous intestinal perforation before surgery? Thank you.
So his question is, how do you differentiate neck from spontaneous intestinal perforation? Dr. Egoche, is it
Yes,
possible?
yeah,
Yes.
it's not possible to differentiate it. So it is only an intraoperative diagnosis. Before surgery, the only thing you can have is a radiograph showing pneumoperitoneum, and for a preterm baby, that is almost like that is Bell stage 3 necrotizing enterocolitis. But when you get into at surgery, the baby makes it to laparotomy, you find this finding, and you make the diagnosis of spontaneous intestinal perforation. It's not a diagnosis that you can make pre-op. I don't know if that answers the question.
Thank you very much, sir.
And probably
Does anybody else
add
have?
to that, necrotizing enterocolitis, as we know it, is not a disease that occurs just on one day. It's more of a protracted illness, that, and you see it coming, so you have that luxury of having that information. Yes.
Thank you. Are there any other questions? Can you unmute yourself if you would like to ask a question and then go ahead? I'm not seeing the hands coming up.
Maybe in the chat box. Can you check the chat box if there are any comments there?
The lecture was so good that there are no questions, not in the chat box, and no hand up at the moment.
Dr.
So in
Obuani
that
has
sense,
his hand up.
okay, Dr. Buani, your hand is up now. Please go ahead and ask your question. Please unmute yourself, Dr. Buani.
Okay, Dr. Mbam also has his hand up.
Dr. Onwe Olivamba, please go ahead with your question. Unmute yourself and go ahead. Kindly unmute yourself and go ahead with the question, Doctor. I don't see anybody speaking.
Hello, good afternoon, ma.
Good afternoon. Thank you. Please go ahead.
Okay, please. Thank you for the lecture. For the first speaker, I just want to know the management protocol for neck in your center, or if there's a national protocol for possibly the antibiotics you use. Because I saw where he wrote triple antibiotics. What specific antibiotics that has been shown to be more really effective in management for neck? Thank you.
Okay, thank you so very much for that question. You're asking if there's a protocol for management of neck. There's a national protocol. If you have access to the comprehensive guideline of newborn care, there's a segment on necrotizing enterocolitis speaking to the disease and how to manage it. So there's a guideline in that book. But you'll find that more often than not, each child may be different. So if you have a sensitivity pattern as to what is the likely organism, that will be that will be the 2 drugs that you're likely to use, or maybe the 1 drug, depending on your cultural sensitivity. But if you don't even have a cultural sensitivity, you're likely to use a drug that will cover a gram-positive and a gram-negative. Then you add for anaerobe cover, adding metronidazole, and that's what makes it the triple therapy. Okay, so each center has its first line choice of antibiotics and then the second line choice of antibiotics. So I would say it's individualized for now, but in the national guideline, there's a template as to what one can use. I hope that answers your question. If you're hoping I'll tell you ampicillin, genticin, and metronidazole, it may work for you, it may not work for me in my center. So that's why it's individualized, but best guided by a culture report.
Thank you. So, is there anybody else who has a question? You can put it in the chat, or you can raise your hand or mute yourself and speak, please.
Maybe Dr. I don't know if Dr. Disu is here or Dr. Obuani. Maybe they can share their experience with us on the outcome of neck in LASU. Is it as poor as we're seeing it in across the country? Are you seeing a lot of neck, or you don't manage very tiny babies? Just to stimulate the discussion.
Dr. Obuani, please unmute yourself. Is Dr. Obuani with us? Oh, no. Okay, it doesn't look like Dr. Obuani is tuned in. There's some kind of accreditation exercise going on in their unit today.
Oh, okay.
So he mightn't be all with us. at all times. There's an external accreditation team on the premises for something that the neonatology team is addressing. So please, can anybody else who has a question, please go ahead and ask a question. Okay.
There's some chat.
Kathleen Lawal would like to know if there's a place of ultrasonography.
Yes, the I don't know. I think my slide on radiological and diagnosis. The role of ultrasonography has come up right now and has gained a lot of wide acceptance. Ultrasonography is able to pick out a lot of features. The features even on X-ray. Ultrasonography is able to pick out the pneumatosis intestinalis, that is the gas in the wall of the bowel, the portal venous gas. Ultrasonography can pick it up. Then the thickness of the bowel wall, and more importantly, the perfusion, the arterial perfusion, the venous perfusion. So the ultrasonography is even been able to predict, okay, this bowel is ischemic, the ischemia is worsening, or there is no blood flow at all. So the prospect of ultrasonography being used to guide the selection of patients have gained wide acceptance. The only problem is the skill set, the skill by the sonographer to be able to bring out all these features is still lacking. And it's lacking in many centers and among the sonographers. And more importantly, these are very small babies. In many centers, you cannot wheel this kind of babies to the ultrasound room. So they have to be mobile ultrasound, and then institutional protocol that helps sonographers or those skilled sonographers to come and do this sonography. So the role of ultrasound is very, very important right now in the management of necrotizing enterocolitis.
Thank you, sir. I hope that answers the question. Can Dr. Onwell Oliver Mbam please go ahead with this question, unmute yourself and ask your question. After that, we'll take Dr. Chinyere Ani, and I saw a few more hands after that. Then we'll take them in order. Thank you, Dr. Onwell Oliver Mbam. Please go ahead. You're unable to unmute. Can we take the next person? Annie, Dr. Annie, please. Go ahead, unmute yourself and ask your question. Okay, she wanted to know about non-steroidal anti-inflammatory drugs, whether it's for the mother or the infant.
Oh, okay, yes. We mentioned the role of NSAIDs, like indomethacin for the treatment of PDAs. So prolonged use of indomethacin, we know, can cause erosions in the bowel, okay? And that can also contribute to the development of necrotizing enterocolitis. So it's used in the baby, not used in the mother. I hope that answers your question. The same applies to steroids.
Okay, because I was going to say there's a related question about steroids as well.
Yes.
And Dr. Dr. Annie would like to know what the risk factors for necrotizing enterocolitis are, separate from the risk factors for spontaneous intestinal perforation. Are they different, the risk factors?
Okay. Like I've mentioned, the risk factors, like I mentioned, for spontaneous intestinal perforation, babies that I've had NSAIDs because of PDA. Um Babies that let me yeah, babies that yes, and very, very low birth weight babies. That is babies that are below 1 kg and all that. So those are risk factors. But like I said, I mean, pre-operatively, you cannot actually differentiate these two entities. It's only when you get intra-op, then you discover that this baby has only one single perforation, and all the other features that you expect in necrotizing enterocolitis may not be there. But clinically, prior to surgery, you cannot differentiate this group of patients. And it's a debate. I mean, although it's gaining ground now that this may be a completely separate entity, but some may disagree that this is another spectrum of the manifestation of necrotizing enterocolitis.
Yes, so maybe just to also add to that, usually for spontaneous intestinal perforation, as you rightly said, it's more common in extremely low birth weight babies. These babies may appear apparently healthy. They're not like the kind of babies that you label that have gone through the charade of developing necrotizing enterocolitis. So they are not like sick, they haven't been with you for a week or two and having the gradual onset of problems. So those with spontaneous obstructions, usually it's an abrupt thing. So that's maybe a clinical way, but the more definitive way, of course, would be in the theater. Yes. Thank you so much.
Thank you. Are there any other questions?
We're running behind schedule.
Okay, so in the absence of any other questions, I'd like to once again thank Dr. Igoche and Dr. Muktayola for an enlightening discourse on necrotizing enterocolitis. Now the hands are going up, lots of hands are going up. Oh, they are clapping. Okay, I thought they were raising their hands to speak. Thank you very much, ma'am and sir, for honoring the invitation and for doing justice to the subject matter. Thank you so very much. God bless. Now we're going to take goodwill messages, and I would like to start with the um, the elders that I see that are still logged online. So in that light, I would like to call Professor Ifoma Emodi. If you are still online, please give a goodwill message to Prof. Njokanma. He can hear you. If Professor Modi is not online any longer, can Professor Ikefuna please give us his goodwill message?
Well, good afternoon, the distinguished House. And congratulations to my brother, very close friends, now smiling, Professor Njokanma. Today is a special day, and I thank God for what He has done in your lives and in terms of serving humanity. It is my prayer that God will continue to strengthen you and guide you in the years ahead as you continue to do this service. And at the same time, I pray that the mercies He has showed on you will be showered to all of us in this house. Congratulations once again, and thank you all.
Thank you very much, Professor Ikefuna. Is Professor Ogala still online, sir? If you are still online, sir, please can you give us your goodwill message? And if Professor Olushola Ogunfowora is still online, sir, please could you give us your goodwill message? Is Professor Ogunkunle still online? Please give us your goodwill message, ma'am. Professor Ogunkunle, please kindly unmute and give us a goodwill message. Okay, in the absence of anybody else's goodwill message, I would like to wrap this up and then invite the HOD Pediatrics LASUT, Professor Idowu Shebanjo, to give his goodwill message and the vote of thanks. Thank you, sir. Please, you have the floor, sir.
Good afternoon, the elders, senior colleagues, and colleagues on the platform. On behalf of the department, I thank you all for joining us in celebrating the birthday of Professor Njokanma. As we all know, it's a very special person, a special breed, a renowned scholar, and an educator, a great one for that, who is dedicated to advancing knowledge and inspiring future generation. And that's for that reason that the department proudly established the annual Professor Fidelis Njokanma lecture. So for today, I want to thank the speaker for this second edition of the annual lecture. I want to thank Dr. Maria Muktayola for the excellent delivery, and then for the co-speaker, Dr. Igoshi, for also it's an excellent delivery. Thank you so much for taking time out to prepare for this lecture. We appreciate your presentation. I also should say that we thank everyone that has taken time, spared their precious time to join us in celebrating this great man, this special person. Thank you so much for joining us. The time you have spent, it's much appreciated. Also want to thank the organizing committee led by Dr. Akinwumi. Thank you so much for all that you have put in place for this second edition of the annual lecture, and everyone that has contributed in one way or the other in making this edition a success. I know that the first edition impacted positively on everyone, and I'm very sure also that this second edition has even been more impactful. And then we'll all be alive to give the testimony in the third edition, which will come up next year. Thank you so much. God bless you all.
Thank you very much. The meeting is hereby adjourned, for want of a better word. We close the meeting now. Thank you so much. God bless you. If you are here in person, we will say, God go with you as you go back to your various destinations. Thank you and God bless.
You mean we hear Oga's voice?
Over to you, Oga.
Thank you very, very much, everyone. At the risk of repeating the thank you message to everybody, I say I appreciate all of you. The chief instigators of this meeting, their collaborators, and accessories. I thank you all. And those of you who took out time, my seniors, my contemporaries, even my children on board, I thank you all. Department of Pediatrics, I'm ever grateful. Thank you. See you same time next year. By the grace of God. Yes.
Happy birthday, Prof. Njokanma.
Thank you so very much.
Wish you well.
Adansi,
Wish you the
very,
very
very
best.
much.
Happy birthday, sir.
My
Many happy
brother.
returns, sir. We love you.
Congrats.
Congratulations, sir. We love you. We love you.
Thank you. Thank you. Thank you.
Happy birthday, sir.
Thank you. Awesome.
Happy birthday, sir.
Thank you. Where is David anyway? Has he taken off?
Happy birthday, sir.
Ah.
Happy birthday, sir.
Thank you.
Good afternoon, sir, and congratulations.
Ah,
sir.
Banker, how are you?
I'm fine, I'm good. Congrats, sir.
Okay. King David, thank you.
Wishing you long life.
Happy birthday, sir. Many happy returns, sir. Many happy returns. God bless you, sir. We love you.
Sir.
We love you. Happy returns.
We love you, sir.
We love you so much.
Thank you, Banker.
Many happy returns.
Thank you. Thank you. Ah.
Congratulations,
Hey.
my brother. Congratulations to you.
Thank you.
So,
Professor Gungule.
congratulating you.
Happy birthday, sir. Wish you long life and prosperity, sir.
Happy birthday to Prof.
Thank you, Professor Gunkule. Thank you very much,
God
man.
bless you. It is well with you in Jesus' name.
Amen. Biola, unmute now. Professor Duale.
Dr. Shola. Okay, maybe she couldn't join the. Okay. Please let's see your face.
Okay, happy birthday to my dear brother. Happy birthday.
Here we are. Thank you, Professor Duale.
I know you. I can perceive your smile from your voice. So I know you have enjoyed yourself today. Well.
We thank
Thank
God.
you.
We thank God.
Yes, so happy birthday. I actually didn't know today was your birthday. I would have asked for
It's yesterday. But you know, my birthday is like.
It's not too late now. Send my cake now. I don't want big cake.
It's a 1 month event. 1 month
I don't
event.
want big cake. I want the real one. Send it.
Let me tell you how it works. From October 1, I start receiving presents.
Wow. Okay. I know what you are
14.
saying. Don't worry. Your presents will come. All right. Bye-bye.
Thank you. Peace. Oh, Peace Opera. She's still there. Peace. I look for you. I look for you in Port Harcourt. I didn't see you. I don't know where you ran to.
I didn't run, no. Happy birthday, sir.
Thank you, thank you, thank you. Okay.
Everybody live stream me your laptop, yes.
You will not always have access to Prof. Njokanma. Talk to him now.
Yeah,
When did Titi join us?
I don't know about any
But
techie
Okay,
thing.
Titi, she
Sonny,
just
how are you?
joined now
Oh, okay.
at the end of the meeting.
Good afternoon, sir.
Good afternoon. Oh. How you doing?
I'm fine.
Titi, you don't want to say anything to Prof?
I'm greeting him now.
It's his birthday. I didn't hear the happy birthday.
What did you say? Angie, what did you say?
I said it's his birthday. Yesterday was his birthday. I didn't
Oh,
hear the happy
you
birthday.
see now? Honestly, I didn't know. Happy birthday, Prof.
Thank you very much, Titi. Thank you.
Oh, happy birthday, sir.
Thank you
I'm
so
sure you
very
had a
much.
nice day.
Thank God.
When I grow up, I'll be like you, looking very young.
Amen. You will even be greater when you grow up.
Amen. Oh.
I guess it's safe to leave now.
Yes, sir. Did I see? Okay. I thought I saw
No,
Bunlomo, not Bunlu. I was
no,
wondering.
it's Faguyi that you saw. Sheung that
Okay.
you
I
saw.
thought I saw Professor Adejude actually. Thank you, everyone. Thank you. Thank you, Prof.
Hey, Sheung, welcome. Oh. Yeah, thank you. Thank you so very much. All right.
Where are you coming to this year? No gifts.
All right, Sheung, how are you?
Lecture.
Fine, thank you, sir. Good afternoon, sir.
Uh-huh.
Yes, sir.
Good afternoon. Lower your hand though, before it starts spinning you.
Oh, yes, sir.
I was last year.
All right. See you guys.
All
Thank you
right,
so very
so
much.
bye.
What was named? Okay. No, I'm not saying that there were no gifts this year. Okay. Because last year was really brainstorming. What do we give? It won't be appropriate. This is that. Okay. Okay. Well, that's fine.
If you log out now, okay, because you are the one
Live streaming.
let me just try it. Meeting has ended. I'll be tablet. Let me see.
Let me just. I want to clear out that room. Sure, you wait for me. The live.
Okay, I can stop streaming.